Ventricular tachyarrhythmia. Classification of ventricular tachyarrhythmia. 1. Premature ventricular contractions, PVCs, which may present as unifocal, uniform, or multifocal, multiform, single PVC, ventricular bigeminy, trigeminy, quadrigeminy, or couplets, 2 successive PVCs. 2. Ventricular tachycardia, VT, defined as 3 or more successive PVCs, at a rate faster than 100 per minute, and may present as salvos, 3 to 5 successive PVCs, non-sustained VT, more than 5 successive PVCs and lasting shorter than 30 seconds, sustained VT, lasting for 30 seconds or longer, or ventricular flutter, used, by some, to indicate a very rapid monomorphic VT, with no isoelectric interval between successive QRS complexes. 3. Ventricular fibrillation, VF. Premature ventricular contractions, PVCs. PVCs are common in both structurally normal and structurally abnormal hearts. PVCs are not usually hemodynamically significant, unless very frequent, more than 30,000 per day, or there is systolic ventricular dysfunction. Whether PVCs predict future cardiovascular events is controversial. Origin of ventricular arrhythmias. Ventricular arrhythmias originate in the His-Purkinje system, distal to the bifurcation of the His bundle, or in the true ventricular myocardium. Accordingly, ventricular arrhythmias are characterized by 1. Wide QRS complex, resulting from prolonged ventricular depolarization time, due to prolonged conduction time from the ventricle of origin to the other ventricle. 2. Change in the QRS vector, due to change in the ventricular activation sequence. These criteria, however, are not totally sensitive or specific. Unusual PVCs. PVCs may have narrow QRS, when arising in the His-Purkinje system with normal conduction velocity. PVCs may have a similar vector to that of normal sinus QRS. PVCs may have timing little changed from the normal sinus sequence, coming nearly at the expected time of sinus beat. Compensatory pauses after premature beats. The general rule is that premature atrial contractions, PAC, invade the sinoatrial node, and reset it, that is, they stimulate it ahead of time, resulting in less than compensatory pauses. A less than compensatory pause is defined as the sum of the coupling interval, CI, before the PAC, plus the return interval, the pause after the PAC, is less than twice the sinus cycle length. With PVCs, on the other hand, the sinus node is not usually invaded or reset, and the sinus cycle is not interrupted, even with retrograde conduction to the atria. The result is a compensatory pause. A compensatory pause is defined as the sum of the CI before the PVC plus the return interval, the pause after the PVC, is twice the sinus cycle lengths. If the sinus rate is relatively slow, the PVC may be interpolated between 2 sinus beats, with no alteration of the sinus cycle length. Here is the PVC with compensatory pause. The coupling interval, CI, plus the return interval, RI, equals twice the sinus cycle length, CL. Here is an interpolated PVC between 2 sinus beats, with no alteration of the sinus cycle length. Coupling intervals, CI. PVCs are usually coupled to the preceding sinus beat by fixed coupling intervals, but this generalization has exceptions. PVCs originating in multiple foci may have different QRS morphologies and different CI. Even unifocal PVCs having the same morphology may have different CI, as the pathophysiological conditions change. Ventricular bigeminy implies the presence of sinus beats alternating with PVCs, as shown in this figure. Classification of ventricular tachycardia. Ventricular tachycardia, VT, may be classified in several ways. 1. Classification according to the QRS morphology into monomorphic or polymorphic VT. 2. Classification according to the tachycardia duration into non-sustained or sustained VT. 3. Classification according to the etiology. Monomorphic VT. Monomorphic VT is characterized by a single stable QRS morphology from beat to beat, indicating a single site of origin and a repetitive ventricular depolarization in the same sequence. The term ventricular flutter is usually used to indicate a regular, rapid, monomorphic VT, with no isoelectric baseline, between the successive QRS complexes. Here is a diagram of monomorphic VT, characterized by a single stable QRS morphology from beat to beat. Polymorphic VT. Polymorphic VT has a continuously changing QRS morphology indicating multiple sites of origin and a variable sequence of ventricular activation. Examples of polymorphic VT are 1. Torsades de pointes, defined as twisting of the peaks of the QRS complexes around the isoelectric line. 2. Bidirectional VT, defined as beat-to-beat alternans in the frontal plane QRS axis. This is a figure of polymorphic VT, characterized by a continuously changing QRS morphology. And this figure shows bidirectional VT, defined as beat-to-beat alternans in the frontal plane QRS axis. Non-sustained ventricular tachycardia, NSVT. NSVT lasts shorter than 30 seconds, with stable hemodynamics. NSVT may present as salvos of 3 to 5 consecutive impulses, or NSVT of 6 or more impulses lasting shorter than 30 seconds duration. They are considered indicators of high risk for sustained VT or VF in most clinical settings, except in patients with no or mild structural heart disease. NSVT can occur in up to 4% of healthy adults. NSVT during exercise is not associated with increased risk. In this figure, NSVT is shown, lasting shorter than 30 seconds duration. Repetitive monomorphic ventricular tachycardia, RMVT. RMVT is an uncommon form of repetitive salvos or non-sustained VT, and occasionally sustained VT. The most benign form is the Galivarden VT, Parkinson-Pap syndrome, more common in women, which is characterized by runs of NSVT separated by only a few sinus beats. VT rate does not usually exceed 150 per minute, but may be greater than 200 per minute. QRS patterns usually suggest right ventricular outflow tract, RVOT, origin, left bundle branch block pattern. Enhanced automaticity is the likely mechanism of this condition. RMVT is shown in this figure. The runs of VT are separated by a few sinus beats. Sustained VT. Sustained VT is defined as VT lasting longer than 30 seconds, or requiring termination in less than 30 seconds because of hemodynamic compromise. Sustained VT is generally considered life-threatening. Benign forms of sustained VT do exist in persons without apparent structural heart disease. Runs of VT shorter than 30 seconds, that impair the hemodynamics enough to cause symptoms of reduced peripheral or central nervous system blood flow, are considered the functional equivalent of sustained VT. Classification of VT according to etiology. 1. Idiopathic VT. 2. Channelopathies associated with VT and VF, long QT syndrome, short QT syndrome, Brugada syndrome, and catecholamine-mediated polymorphic VT. 3. Organic heart disease associated with VT, particularly ischemic heart disease, cardiomyopathy, myocarditis, and congenital heart disease. 4. Drug-induced VT. 5. Traumatic VT, commotio cordis. Thank you.